This is a short video that will include a basic overview of shock and the hemodynamic management of several types of acute shock. Shock is defined by tissue hypoxia secondary to circulatory collapse. This is manifested in several ways. First is hypotension, often defined as a systolic blood pressure less than 90. Next is hypoperfusion, or decreased blood flow and oxygen delivery to tissue. Evidence of tissue hypoperfusion includes neurological dysfunction, as well as decreased urine production and tissue hypoxia, often seen as cool, clammy skin. Finally, the key laboratory parameter is an elevated lactate, typically greater than 2.2. Shock can be divided into 4 basic types. Distributive shock is the most common type. Examples include septic and anaphylactic shock. The essential problem is massive systemic vasodilation. In contrast to most other types of shock, it often presents with warm skin and increased cardiac output. Cardiogenic shock occurs when there is an inherent problem with or damage to the heart, such as an arrhythmia or myocardial infarction. This results in decreased cardiac output. Obstructive shock occurs when something outside of the heart causes failure of the heart's pump function through vascular congestion or mechanical forces. Examples include pulmonary embolism and tension pneumothorax. Finally, hypovolemic shock results from intravascular volume depletion. Etiologies include hemorrhage, burns, and GI losses. Now we have a basic understanding of the types of shock. How do we approach treating it? One way to remember the basics of shock care is to think VIP treatment. V stands for ventilate. Patients may require supplemental oxygen and even intubation. Indications for intubation include severe dyspnea, hypoxemia, and persistent or worsening acidemia. I stands for infusing fluids. A 500 cc fluid challenge over 20 to 30 minutes is a reasonable first step. Monitoring for response to fluids is important. Increased blood pressure, decreased heart rate, and increased urine output are encouraging signs. Let's take a detour into the world of IV fluids. There are many choices, and there is little data to suggest any one fluid is superior. In general, the first choice fluids for initial shock resuscitation are balanced crystalloids such as lactated ringers or plasmolite. In septic shock, there is some evidence of decreased mortality if albumin is used. In hemorrhagic shock, resuscitation with blood products is indicated. Although normal saline is affordable and readily available, large volumes can cause worsening acidosis and elevated chloride. Balanced crystalloids are generally preferred, except in the case of hypochloremic metabolic alkalosis, where the drawbacks of normal saline work to our advantage. Back to our VIP treatment. P stands for pumping in vasopressors and inotropes. Let's take a physiology detour into the world of adrenergic receptors and their effects. There are 4 types of receptors to review. Alpha-1 receptors are present throughout the peripheral vasculature. Activation of these receptors results in vasoconstriction, particularly of arterioles, increasing systemic vascular resistance. Vasopressin 1a receptor activation mimics and augments alpha-1 activation through multiple mechanisms. Beta-1 receptors are concentrated in the myocardium. Activation results in increased myocardial contractility, also called increased inotropy, and a faster heart rate, also called increased chronotropy. Beta-2 receptors are present in the vasculature and liver. Activation results in peripheral vasodilation, particularly in skeletal muscle. It also results in increased glucose and lactate production in the liver. Let's take this knowledge and apply it to 7 common vasopressors and inotropes: norepinephrine, phenylephrine, dopamine, vasopressin, milrinone, dobutamine, and epinephrine. First, let's think about these medications by their primary receptor interactions. Phenylephrine and vasopressin both have almost exclusively alpha-1 effects. Dobutamine and milrinone have strong beta-1 effects as well as moderate beta-2 effects. Norepinephrine has a strong alpha-1 effect and mild beta-1 effect. Dopamine and epinephrine fall in between. Their effects differ with dosing. High-dose dopamine has primarily alpha-1 effects, while low to mid-dose dopamine has more beta-1 activity. Low-dose epinephrine similarly has beta-1 effects, while high-dose epinephrine has much stronger alpha-1 activation. Now let's classify these drugs by their relative vasoconstrictive and inotropic effects. As you might suspect, phenylephrine and vasopressin have the greatest vasoconstrictive properties. Dobutamine has powerful inotropic effects and is mildly vasodilatory. Milrinone has moderate inotropic properties, but significant vasodilatory effects. Norepinephrine lives in a happy place of strong vasoconstrictive effects and moderate inotropic effects. High-dose epinephrine slots in just below norepi on the vasoconstrictive scale with greater inotropy. High-dose dopamine and low-dose epinephrine have similar inotropic properties, but dopamine has more vasoconstrictive power. Finally, low-dose dopamine is generally neutral in terms of vasoconstriction, but has stronger inotropic effects. All of these medications have drawbacks and advantages that we can use to help guide selection, so which medication is best for each type of shock? The essential problem of distributive shock is vasodilation, so the ideal vasopressor has strong vasoconstrictive properties. The first-line agent is norepinephrine, with its excellent vasoconstrictive properties and mild inotropic support. If norepi does not sufficiently improve blood pressure, second-line vasopressors include vasopressin and high-dose epinephrine, which can be added. Phenylephrine can also be used if norepinephrine triggers tachyarrhythmias. Dobutamine is indicated in distributive shock with concomitant cardiac dysfunction. Dopamine should only be used if there is relative bradycardia and low risk of tachycardia. In obstructive shock, the first-line agent is again norepinephrine. Second-line agents include dobutamine if more inotropic support is needed, as well as high-dose epinephrine and dopamine for blood pressure support with moderate inotropic support. Dobutamine is the first-line agent for acute cardiogenic shock. One major advantage is its short 2-minute half-life. Dobutamine can trigger hypotension given its beta-2 effects, so norepinephrine is often used in conjunction. Milrinone is a second-line agent. It can be useful in patients with chronic heart failure who have downregulated or pharmacologically blocked beta-1 receptors. Milrinone tends to cause hypotension and has a half-life of 2 to 3 hours, even greater in renal failure, which limits its usefulness. The ultimate treatment of hypovolemic shock is intravascular repletion. Norepinephrine is again commonly used if fluids do not correct hypotension quickly enough. In undifferentiated shock, the overall approach is fluid bolus followed by our shock workhorse, norepinephrine. How do we know when our treatment is working? The goal of resuscitation is restoration of end organ perfusion. We monitor this with blood pressure, urine output, and lactate. The target mean arterial pressure is greater than 65 to 70. Target urine output is greater than 0.5 cc's per kilo per hour. Ideally, lactate should decrease by 20% in the first 4 hours of resuscitation and continue to trend down. In summary, the hemodynamic management of acute shock can be broken down into 3 steps: the VIP treatment, ventilate, infuse fluids, and pump vasopressors and inotropes. Goals of resuscitation include a MAP greater than 65 to 70 and restoration of end organ perfusion as indicated by decreasing lactate and appropriate urine output.